So thanks everyone for coming today. I'm Cheryl, I'm the CME Committee Trainee Rep, and welcome to the first combined ANZCA CME Committee meeting for 2017. Thank you very much to our sponsors for coming, Avant, MSD, ICU Medical and Sakairis. Tonight we are very privileged to have Associate Professor Bernd Froessler speaking to us on the perioperative management of anaemia. He is a consultant anaesthetist at Lyell McEwin Hospital and has a specific interest in perioperative blood management and also neuroprotection. He has over 300 publications, including 12 books, and he's been heavily involved with the National Blood Authority Working Group, the National Anaemia Management Advisory Committee, and the SA Blood Management Council. So if you could all please assist me in welcoming him to the stage. Thank you.
Thank you very much, Cheryl, and thank you very much for having me. I just have to make a slight correction here. I wish I had that many publications.
That was a lot, but I didn't want to question.
No! Not anywhere near. But that's okay. I hope I still won't disappoint you. And I guess if I had that many publications, I wouldn't have a life. And it's actually a real privilege to speak here tonight because it's my 20th anniversary in South Australia or in Adelaide as an anaesthetist, believe it or not. And I was doing the grand round at the Lyell McEwin yesterday, and the organiser introduced me and said, "Oh, he's probably been here for about 10 years." And I said, "Well, make it 20. And it sort of kind of was a bit of a shock when I actually said it, and it's been 20 years. And Guy Christie-Taylor, who's in the room, and I, we both started out at the Lyell McEwin. We arrived on the same boat. And I remember going to the second part course being taught by David and others, and finally got recognition, and the rest is his history. Now, I mean, the people who worked with me at the Lyell McEwin know that I have a big passion for this. A bag of blood is a little bit like a red flag. And so I just want to take you tonight through the concept of patient blood management and showcase a little bit what we've done and why, if you're not doing this already, you might want to consider to embark on this. And I want to share with you a couple of publications we've had and show you some results. Now, what I'm going to do is hang on, is this? Okay, now we're on. Now, the way I structured this presentation is I want to tell you a little bit about the history of patient blood management and how we ended up there. I then have to talk a bit about blood, or generally about transfusion, and I will talk a little bit about iron deficiency, which is, well, not actually a little bit, I will talk a fair bit about iron deficiency, which is the most common underlying cause for anemia. I'll give you a couple of cases and talk about money. I will, even though this is mainly focusing on the preoperative assessment and preoperative optimisation of patients, but I will show you what you can do if you missed the boat. And then I will talk a little bit about the future, what the future holds, what we should be doing, what the Australian government is doing, and what hopefully most hospitals around SA will be doing soon. Now, this is not new. Back in 1958, there was an editorial that was published in the New England Journal of Medicine, and Dr. Crosby at the time commented on a common practice, and he referred to patients prior to major surgery the day before when they were admitted that they would get a litre of blood to prevent chronic shock. Now, and he noted that one of the patients, for example, was transfused to a hemoglobin of 18, and then he warns already back in 1958 that would probably be an inappropriate transfusion. And he goes on in his editorial to say that the thoughtless prescription of blood is really playing Russian roulette and the patient takes the risk. And then at the end he says, well, what do you really treat? the patient, the lab report, or your own anxiety. And this, we still find a hell of a lot going on in clinical medicine, where we treat either numbers or we treat our own anxiety because we don't dare to the whole transfusion. What I'm going to focus on is really transfusion in the elective surgical setting. And so it's not the trauma setting, but almost 80% of our blood products actually go to the elective surgical setting, and the rest is swallowed up by trauma. Again, going back in time, and this is 1988, the talk around transfusion and products was very different at that stage because it was very much influenced by the HIV epidemic. But James Isbister, who's an emeritus professor and hematologist from Sydney, is still very active in the patient blood management arena. And he stated in this paper that there's no clear indication to transfuse a patient at a hemoglobin of bigger or larger than 80. And again, two eminent people in these publications. One is James Isbister, again 1985, and Tim Goodnow from Stanford. And you will, if you have read around this topic, come across those names over and over again. They already in the early 90s pointed out that there are various ways of avoiding transfusion and optimizing patients and actually implementing patient blood management modalities, even though it wasn't really called that at the time. But Tim Goodnow and his group, they talk about several therapeutic strategies, pharmacological interventions that you can apply to reduce operative and non-operative red cell usage. And James already pointed out what's actually now happening, that the next paradigm would shift from a donor, so a product focus, to a patient focus. The whole patient blood management, I don't really want to call it a movement, but concept, gained a lot of traction with this publication from Paul Herbert from a Canadian group. And that's the famous TRIC trial that many of you might have heard of, that was set in the ICU setting, and they randomized patients to a restrictive versus a more liberal transfusion approach in a patient cohort where most of us at the time always thought that a higher hemoglobin level would be beneficial or even needed for the patient to avoid morbidity. And what they found is that the restrictive group, and restrictive meant between 70 and 90, actually did not worse than the liberal group between 10 and 12. So blood is not an inert drug or product. Blood has a lot of implications. It's a very scarce source, and we know that we currently have a lot of problems in meeting the needs of our inventory. The Australian Red Cross has already released on a number of occasions a blood contingency plan, which meant that certain hospitals, certain patients would have been preferenced when it came to transfusion. And Australia has been particularly proud of the fact that we have a balanced, or used to have a balanced donor and recipient equation, and particularly in a country where the donors aren't paid. So the donor, they donate obviously in an altruistic fashion. They do it because they want to help society, and they also believe that we as clinicians treat this product with respect and give it to the patients who really need it. So we all know the slogan, give blood, save life. Yes, of course, we have to continue to do that because there won't be medicine without blood. But but if we use that blood or utilize the blood, we have to do it appropriately. You might have heard of the Choosing Wisely campaign, and this is very interesting. Blood is important, but blood is one of the 5 most overused treatment modalities in the world. And so in this publication, the campaign points out 5 things that physicians and patients actually should know. And interestingly enough, 2 out of those 5 are related to patient blood management. The first one is sampling of blood, that we should not test only for the purpose of testing, and we're very good at testing but not looking at the results or not acting on the results. But the second one is more important, that you should not transfuse a patient, a stable, hemodynamically stable patient with a hemoglobin greater than 7. And what really again is pointed out here, that the hemoglobin threshold in the absence of active coronary artery disease, heart failure or stroke, the patient should not be transfused to a number, the patient should be transfused to symptoms if that's the case. And that blood is not an inert product has been really nicely shown in this publication, where not only that they showed if patients were transfused that they did worse, but also that it is dose dependent. The more blood you get, the higher the risk is that you will suffer morbidity or mortality. And what they conclude in this paper is that it's likely that even discretionary amounts of intraoperative blood leads to increased mortality and morbidity. This was also shown in a very nice publication in the BMJ from 2015 by this group, where they looked at 1.5 million patients and 41,000 transfused patients. And what they found, again, that transfusion is an independent risk factor for morbidity and mortality, and that patients who got a single unit of blood in the perioperative setting suffered a higher incidence or a higher odds ratio of having a myocardial infarction or a stroke in the perioperative setting. So it is really something that we should think about. And when you think about the impact of 1 unit of blood, this is the unit that very, very often we could avoid if we allow the patient to be prepared well and if we avoid the patient to go into surgery anemic. That's another publication, and they didn't look at like a 30-day mortality or morbidity, but they looked at long-term outcomes after colon cancer resection. And again, the result is the same, that your death over 5 years from cardiovascular causes is higher if you had either transfusion in combination with sepsis or transfusion in isolation compared to neither of those. And the same also when you look at the time to death from any cause within 5 years, it's exactly the same, even a little bit more dramatic. Interesting publication in Nature 2015 from Stanford, where Tim Goodnow is, and what they did is they looked over a year at patients again who received a transfusion, but every time the clinician ordered a transfusion, a window would pop up. It was an electronic ordering system. A window would pop up and remind the clinician to review the indication for that particular transfusion. And what they actually achieved by doing that was a reduction in transfusion by 24%. That saved that hospital in a year $1.6 million. They had a significant reduction in length of stay, and they had a decrease in mortality by transfusing less. All these patients were transfused. And what they also conclude in this paper, this is really worthwhile reading, is that weaning doctors of their love affairs with blood is going to be harder than we think. And I can attest to this, and when I remember also working with one of the surgeons at the Lyell McEwin many years ago, who also had a bit of this attitude, big surgeon, big cut. But then, there was, when it looked a little bit oozy, the surgeon would already ask for a transfusion. And after about 3 years, he kind of gave up and he said, "Oh, you're not going to transfuse anyway." And I said, "Yeah, you're right, I won't." And so in the end, he came to the party and also understood that intraoperative hemostasis is a very important thing. Patient blood management is not an individual sport, it's a team approach, and you can't do it on your own. And so if you work your heart out in theatre trying to avoid transfusion, you do all the things, the right things. The surgeon even does a proper hemostatic approach. But then if your patient goes to ICU and the team on ICU has let's say a protocol-driven transfusion approach, you don't really win. And I just want to remind you really briefly of the complications of allogeneic transfusion. And it's not hepatitis, it's not HIV, because here we're talking risk of 1 in 2 or 1 in 3 million. But what it is the immunosuppression, so the immune modulation that leads to conditions like TRALI and we know that your TACO, so your circulatory overload with patients ending up in heart failure is a problem. We know alloimmunization is a problem. That's particularly relevant in the young population, so if we talk pregnant women or peripartum transfusion. And then, because we do transfuse not only red cells, it's a mini organ transplant. So there's a lot of donor cells that go into the recipient. So microchimerism means that these cells of the donor, of the product that the patient receives, float around in that patient for many years, and they've been documented for more than a decade in the patient. Now, and where in the discussion around microchimerism, there is also then the risk of the blood-borne cancer, that you actually might kind of inherit the risk by the donation or by the product that you receive. But one of the really pivotal things and most important things in this kind of context is that transfusion is not a modality to treat iron deficiency. Most of our patients who are anemic are iron deficient. And yes, of course, by giving blood, you give a certain amount of iron, but it is never enough to actually restore iron stores appropriately. So this is where patient blood management then came along, and patient blood management has been was born, or the concept and the term was born by by SABM, which is the American Society of Blood Management. But I do like, and there's multiple definitions around, but I do like the definition of the International Foundation of Patient Blood Management, that it is an evidence-based bundle of care to optimize medical and surgical patients. We also have to understand, I mean, most of us, obviously, we work in the surgical setting. It is the perioperative patient that we look after, but transfusion happens a lot in medicine. It happens, so this concept really applies to every speciality in medicine where transfusion is a modality. And if you think PBM and you look at the evolution of the PBM literature, is quite dramatic. It's really exploded. I got involved, or at Lyell McEwin, we got involved in around 2006. And I was privileged enough in 2007 to go to Englewood Hospital in New Jersey, where Arya Shanger works. He's the professor of anesthesia there, and he's really one of the pioneers in patient blood management concept. And what these guys already did back in 2007 was actually quite impressive. And I was lucky enough to be sent by the Department of Health, the South Australian Department of Health, in combination with the National Blood Authority, to Englewood to observe what they did. And it was really interesting. That multidisciplinary approach really stood out. They were all on the same page, and they would all work in the interest of the patient to not only and necessarily avoid transfusion, but to make sure that if it was transfused, that the transfusion was appropriate, whatever that meant at the time. And literature and also the approach has come a long way since. They did cater in the US, obviously, as you know, it's sort of a mixed private-public setting, and there's also benchmarking and hospital advertised. And this hospital had a department of bloodless medicine, and they catered for a lot of Jehovah's Witnesses. And from the Jehovah's Witness population in the transfusion space, we actually learned a lot, because we obviously had our trials without ethics approval. And because there was obviously no possibility to transfuse those patients, so the boundary was pushed further and further and further. But what we did find over time, and there's multiple studies out there that showed that Jehovah's Witness patients matched with non-Jehovah's Witness patients who might have received transfusion, that they actually did better. They came into hospital better. They obviously had higher hemoglobins. They had higher hemoglobins coming out of surgery. They had shorter stay in ICU. So in the end, I also always decided that if I ever had major surgery, I would tell everyone, or if I couldn't do it myself, get my wife to tell everybody that I was a Jehovah's Witness. I mean, that was years ago. So I would actually be treated. And you all remember when a Jehovah's Witness hit the hospital, everybody knew about it. And the Jehovah's Witness patients would get, in my view, preferential treatment, but preferential, not in a negative way. It's actually the treatment that we should all receive going into major surgery. So how did we start? We looked at our transfusion approach at the Lyell McEwin. And if you look at this transfusion audit, you will notice a couple of things. And if we start with the pre-transfusion hemoglobin, and in 2002 the NHMRC released this sort of little booklet, guide on transfusion approaches, and so when to transfuse and not transfuse. And so we could actually argue at the time already, we didn't actually do that badly when it came to the so-called transfusion trigger. The literature and the people involved in patient blood management, like I said before, try to move away a little bit from the number, and the transfusion should not necessarily happen according to a number, and you have to look at the individual patient. But what really stands out is two things. One is that the patients then were over-transfused. And we all, or many of us, learned at the time, and when I trained, I learned one is none. So you kind of gave a minimum of 2 units, but now we sort of really turned this around and we said, why give 2 if 1 will do? In Western Australia, they have implemented a patient blood management program many years ago, and the lab actually has the authority to only dispense 1 unit when the clinician asks for a non-trauma patient, and then the clinician has to prescribe that 1 unit. The unit is given, patient has to be reassessed, and with this single unit policy, they had a massive success in reducing not only obviously product consumption, but also avoiding morbidity and mortality, and I will show you some very, very impressive data a little bit later. What we know is anemia is not a good thing. It's not a good thing in isolation, it's certainly not a good thing when you come into surgery. And what we do know is that if patients get transfused, or if patients go anemic into surgery, and particularly large surgery, obviously they're much, much more likely to be transfused. But again, coming back to the immune modulation and the immunosuppressive effect from transfusion, we also know that they suffer more from infection, and particularly orthopedic surgeons, they have taken this on board a while ago, and they're not keen for their patients to be transfused, and they're actually one of the surgical groups, at least I don't know across the board, but our orthopedic surgeons are actually very happy for us to avoid transfusion, because they're also keen not to transfuse because the risk of infection is quite high. This is a very nice publication from The Lancet 2011, looking at more than 200,000 surgical patients in non-cardiac surgery, and what they found is that even anemia to a mild degree is an independent risk factor with increased morbidity and mortality at 30 days. And so this brings us now to the concept of patient blood management. The concept really consists of 3 pillars, and the first pillar is the preoperative approach, the second pillar is the intraoperative approach, and the third pillar is sort of the postoperative approach, where you have certain modalities that you can apply to improve the patient's outcome and optimize patient's red cell mass. And as you can see, I've given the first pillar. I mean, this is really what this talk is about. I sort of gave this a lot of importance, and not only because it is the most important, but it is also the hardest to implement. But if you do this right, the other 2 actually become almost negligible, because your patient will do well, and you don't even have to go there and harness and optimize physiological reserves of anemia. Yes, anemia tolerance is very, very important. But in this clinical setting, what we find is actually really hard is that it's actually not the anemia tolerance of the patient that's so hard to address, it's the anemia tolerance of the clinician that's so hard to address. So if you get this right, you're on the right track, and so it's all about iron. Registrars over the years had a lot of fun sticking up posters on my door, calling me Iron Man, and giving me little whatever presents, and putting up articles about iron-enriched food, and I think that's very amusing, but it's true. So iron is actually obviously not only important for making red cells. So there's a hematological component, obviously, to that. We need iron to make hemoglobin. And if your red cell is a bit low on iron, it actually is not very happy, and it might actually at some stage need some oxygen. But there is also a lot of other mechanisms where iron is involved. Iron is the most important trace element in our body. We only have 0.008% of our body mass is actually iron, but that is absolutely vital. It's involved in a lot of enzymatic processes. It is vital for energy production. It's vital in the cardiac muscle, in myoglobin, and it's also vital for the brain. So the end result, if you don't have enough, is kind of this. You're feeling not particularly great. And so therefore, I will show you what it does, or what you can do by treating your patient appropriately. There are obviously two ways of giving iron, and there's the oral and the intravenous route. Intramuscular administration of iron is out and should actually be prohibited. It hurts, it stains for life, and it's not any less risky than giving it IV. However, it's still done in quite a few places. So if we look at the oral iron formulations, and I just highlighted the ones that we have available, ferrous sulfate, ferrous fumarate. Actually, and this is slipped, I don't know, I highlighted that as well because this is new. This is iron polymaltose, oral iron polymaltose. And in the IV formulations in Australia or in South Australia, we have ferric carboxymaltose, iron sucrose, and iron polymaltose has been around for a long, long time. There's a couple of differences in these formulations. This you can only give in small doses every 24 hours, 200 milligrams maximum. Iron polymaltose is the only IV iron that you can actually give a full dose infusion, but that takes many, many hours and also has a significant number of side effects. And ferric carboxymaltose is kind of the new kid on the block. It's been around now for about 5 years. And you can give up to 1,000 milligram in one setting, and you can give it over 15 minutes, and it's fairly safe. Now, if you do prescribe iron, you should really prescribe the type of iron that works. And there are about 40 products in South Australia available that contain iron. And Catherine Robertson, she's a haematologist, works for the Red Cross and also works at the Queen Elizabeth Hospital. She did a very nice project when she had her third child, and she was very pale. She went to the pharmacist and said, "Oh, my doctor told me that I'm iron deficient, and what can you recommend?" And 32% of pharmacists advised her actually of the wrong drug. And some of the drugs that are out there, 35 out of those 40, you need 40 plus tablets to get an adequate dose of iron that actually will make a difference. And no wonder that people have no side effects from it. So we have in pre-admission clinic this chart, and this chart actually, quite often the patient, they say, "Oh, I'm on iron." We show them the chart and they said, "No, it's none of those," and then we know it's not a type of iron that actually has enough iron. So we tell them to get the right type of iron. This is the iron polymaltose that I was talking about, came onto the market in Australia in December last year. Can be taken with food, is better tolerated according to the studies. It's a little bit more expensive, and it's also a little bit safer. But however, many patients respond very well to ferrous sulfate, which is given to a lot of patients in our country. A couple of cases. Now, this is a lady, 56 years old. At the time when I saw her in pre-admission clinic, presented for a total knee replacement. At the time in 2012, I was already with my head in this space, and I thought, okay, well, we did the standard testing, CBC, EUC for most patients and a group and hold, but at the time I also liked testing for iron deficiency. Now, major arthroplasty is a big operation with significant blood loss, and you know that all our patients drop their hemoglobins 3 to 4 gram in their perioperative setting, so you really want them well prepared, and particularly the female patient who tolerates anemia or blood loss a lot, particularly if they're small, less than males. However, this lady said she was well, she felt a bit tired, and she had a bit of a niggle. She said, "Oh, I can't really work out what it is." She was on a non-steroidal, so not an uncommon story. So After I reviewed those results, I gave her a call and I said, well, I have to disappoint you, you're not going to have your joint replacement at this stage. So what we did is I spoke to our gastroenterologist, and she had a scope, top and bottom, and I think this is a very, very important message that we all have to take on. We can't just say, okay, well, we diagnosed iron deficiency, we have anemia, we treat it, and then off you go and you have your joint replacement and everything's forgotten. We have to make sure that we don't overlook, and this is also an opportunity, any malignancy or any other serious cause that can cause a lot of havoc. And if that ulcer perforates that the gastroenterologist found, then obviously you have an emergency which you don't want. Now, she was then treated with a PPI and oral iron at the same time. We reviewed her only 2 months later, and she normalized her hemoglobin and she normalized her iron stores. She had surgery, had her joint replacement, was not transfused, and went home with a hemoglobin on oral iron for the next 3 months with a hemoglobin that was higher from when I saw her. Now, this is a common occurrence, but this is also something that is really not hard to do, and the patient will certainly benefit from it. But IV iron, and I remember at the beginning when we prescribed this more often, was a real drama. There was so much anecdotal evidence around the danger of IV iron. You went to the ward and you wanted IV iron to be given. The nurses were up in arms. They were all happy to put up a bag of blood, but IV iron, oh no, the patient would die at the end of the needle. And so we had a lot of discussions, we did a lot of education, and there's some really nice work that was published by Michael Auerbach. He is a physician from the US, done a couple of really nice papers. So IV iron is safe and has become much, much safer because also we have a lot of new types of iron. The allergic reactions to the older forms of IV iron were mainly due to the dextrane and not to the iron compound. So we now know that there are lots of safe IV irons out there, and but we started, I don't want to say playing with this, but we started using this because we felt that we could do something for those patients. And this is just a small case series that David Papendorf and I published in 2010, and there were a number of patients, and these were all colorectal patients that the surgeon didn't want to delay. Of course, if you have enough time, you can give them a trial of oral iron, you can see how it works and where they go, and you can bring them back a couple of weeks later. Now, these patients had to have the surgery within 2 weeks, and the surgeon was unwilling to delay, so we gave them iron sucrose, and that was what we had available at the time. And iron sucrose, we were using that in a randomized control trial in the obstetric setting, and we saw that this was actually doing a good job. So we gave it to those patients, and if you look at this, within a very short period of time, these patients made the equivalent of a 2-unit transfusion. So they all came into surgery, had the laparotomy, bowel resection, and went home without being transfused. At that time already I'd started designing a randomized controlled trial after I did a systematic review on the IV iron in the perioperative or preoperative setting. And we published this last year in Annals of Surgery. And we published that despite the fact that we actually pulled the plug on this study. We felt at some stage that this was unethical to continue. We randomized patients to IV iron versus standard care, and what we actually started to realize at the 30-day follow-up when the patients were sent to the GPs, that standard care was like placebo. And so I had lots of discussions with people around the place, and many people warned me and said, don't do this, you won't get this published. And we ended up getting this published in the top surgical journal, and after a very hard review process, but the results were really impressive. We decreased transfusion by 60%. The patients went home 2.7 days earlier, and at 30 days, so from discharge to 4 weeks, where our follow-up time was, there was a significant change in hemoglobin. There was also a significant change in hemoglobin from intervention to admission, and the intervention window in this study was 4 to 21 days. And we brought this back to 4 days on purpose because I believed that even a very short period of time, and even if you completely missed the bolt, on the operating table will make a difference. So what we found, and the mean intervention day or number of days before surgery was 8.6 or something in this study, so a very, very short period of time. And many clinicians, and I must say before I really started looking into this, I also believed, oh, maybe it's too late and you might want to do something afterwards. No, but we found that actually doing something before surgery is well worth it. And I'll just show you one patient out of this study cohort. This was a 58-year-old male who had a bowel cancer and was then included, and our inclusion criteria was iron deficiency anemia. However, the iron deficiency, we had a very broad definition, and that was based on the criteria from NATA, which is the Network for Alternative Transfusion Approaches, where they looked at patients with so-called functional iron deficiency and high ferritin levels due to inflammation. So we actually defined this with a ferritin of less than 300 in combination with transferrin sets of 25 or less and anemia. So the cutoff was anemia and iron deficiency. Now this guy had a hemoglobin of 80 and a ferritin of, I think, 4. And so he had profound iron deficiency anemia. Now he was only randomized 7 days prior to surgery, and he was given the intervention, and within 7 days he made the equivalent of 2 grams of hemoglobin. So again, that's the equivalent of 2 units of red cells. So he had a very uneventful surgery. So he had his pre-op iron, and part of our protocol was also to replace the iron loss through blood loss. We all lose 0.5 milligram of iron with a ml of blood, so at a minimum of 100 ml blood loss, we actually gave some iron. So he had a small dose of IV iron on day 1 or 2, I can't remember, but that was sort of the window where that could be given. And so he continued to make red cells at 30 days follow-up. He had almost restored his iron stores, even though back then the cutoff was 15 for true iron deficiency on our lab reports from assay pathology or any other labs really. And he didn't quite recover his hemoglobin completely, but he was on the way. So if you work out from 80 to 117, including surgery, you saved, if you would have given that, or if you wanted to achieve this by transfusion, the equivalent of 4 units of red cells. Not that that's incredibly expensive. The acquisition cost of a unit of red cells in Australia is $350, but this is acquisition cost. True activity-based cost, people would argue, is roughly about $1,000 per unit. Now, the evidence speaks for itself. This is South Australian data, and the South Australian Patient Blood Management has actually done, Blood Management Council has done a lot of work, and there are certain pockets where there is happening a little bit more, and we are one of those pockets. So this is Lyell McEwin data, this is joint replacement data. So there was a consistent reduction in transfusion. This is total hip replacement, and we're currently sitting at about 15%. And with total knee replacement, we're sitting at 5%. Now, and this is in comparison, and I didn't want to name and shame, so I just sort of decided to combine the data between the RAQI, QEH, and the REPAT. But if you compare that data, we are sort of definitely coming out on a lower transfusion percentage. In orthopedics, I must say it's not quite as prominent, because I also think that tranexamic acid is actually being given a lot now in orthopedic surgery across the state. But when you now look in the colorectal space, now that's a bit scary. Are there any colorectal surgeons here from the RA or from the Queen Liz or from Flinders? Now, we have half the transfusion rate at the Lyell McEwin. So we're looking at 15 compared to 30. And I think that is really something that is important, and this is a message, and this is really not shaming or blaming. This is really something that is very, very effective and can be done quite easily. If we look nationwide, and this is data from the National Blood Authority, over the years, transfusion approaches, it has actually been taken on board, and it has been implemented, but there's a reduction of 16%. And if you work these 16%, that is actually a reduction of $40 million in the country every year. Blood products take up about 5 to 7% of the entire health spending, and I think this money would be better spent in other areas. Now, talking money, like I said, $40 million, acquisition cost for red cells about $350. And our blood budget only for red cells is $250 million in Australia every year. This is unpublished data but accepted. We looked with a group of from Germany and from the University of Groningen in Holland at the impact of treating iron deficient patients prior to surgery in an economic model based on the German DRG system. However, this is quite applicable actually, because Germany adopted the Australian DRG system in 2000. So this is very, very similar in the way this is calculated and we get paid. And we extrapolated the data from our study to 100 patients, and the savings per 100 patients in euro in the German model is close to 80,000 euros per 100 patients. Now, I did an economic evaluation based on our study because we had more than 70% of colorectal cancer patients, and I did that only then in the colorectal cancer patient space. And we have about 17,000 newly diagnosed colon cancers in Australia every year. If you work on 30% and 2 days, and I took really the low and the very conservative approach to calculate this, and you look at a reduction in length of stay, you're talking savings of $6.5 million. Then obviously you have your product cost by treating those patients, and transfusion, again, I took a very conservative approach. But in this patient cohort alone, we're talking savings in the order of $6 million a year for the Australian health system. Now, this is the study I sort of alluded to a little bit earlier from Western Australia. Western Australia really led the way in this, and the Western Australian government back in 2008 put $4 million to the implementation of a patient blood management, or the development and implementation of a patient blood management program. That was a statewide program, and many of the people who published this with Michael Lear, who is a hematologist from Perth, and they just published that only a couple of weeks ago, have been involved for all that time. Now, this is observational data, but this is big data. This is more than close to 700,000 patients over the entire patient blood management program that since they began. And so they managed to reduce transfusion by 41%. Product cost for Western Australia alone, and again, product cost, not activity-based costing, close to $90 million. Pre-transfusion levels came down from 7.9 to 7.3. Again, awareness, education. Clinicians were more restrictive in their transfusion approaches. And also by obviously implementing pre-admission clinics where patients for bigger surgery were seen 4 to 6 weeks before, like we do, for example. All our joint replacements we see 4 to 6 weeks prior to surgery. So if there's something we can do that is doable in that period of time, we try and address that, but sometimes obviously it does take a little bit more time, and we have to delay for a little bit before the patient comes to surgery. And what is really quite impressive, and I said that before, is that the single unit transfusion really jumped up. It doubled. So a lot of clinicians would take that approach, why give 2 if 1 will do? And it really made an impact. And so there's a lot you can do. There's a lot to talk about. There's a lot to talk about to surgeons and bring them on board. And there's a lot to talk about on the ward, that actually blood is potentially a more dangerous product than iron. And I just want to illustrate what you can actually do if you did miss the boat. In our study, we also had an approach where we gave iron postoperatively, and that approach was taken to a couple of studies that now have been published. So if you talk patient blood management, and again you look at your pillars 1, 2, 3, I sort of brought in a fourth pillar, which is the first pillar. So this is really optimizing red cell mass, and how do you do that in an anemic and potentially iron deficient patient? You give them iron. So in the post-surgical setting, or in the sort of setting of inflammation, we see this a lot, that patients might not absorb oral iron well, and there's a reason for it, because there's a peptide called hepcidin, or hepcidin, like the Americans pronounce it, that is secreted by the liver, and is now a little bit, is labeled the iron regulatory hormone, really. That was found in sort of early 2000 and has really changed the understanding of iron metabolism. And what it does in the state of inflammation or post-surgical stress, hepcidin is upregulated, and therefore it impairs the sequestration and absorption of iron, and sequestration from the stores and absorption of iron from the gut, so there will be less usable iron, and by giving intravenous iron you bypass that sort of what we call hepcidin block. And so in the postoperative setting, you can actually use this in the severely anemic patient, or in the patient that you hadn't identified prior to surgery of being iron deficient. Now this is a lady that we anaesthetized a little while ago, and we wrote this up, and there were 2 cases in this publication, but I just want to really talk about this. And this lady on the operating table disclosed to Georgina, as a colleague of mine, that she just decided that she became a Jehovah's Witness again. She was one before, and we just felt, oh, bad timing. Anyway, she bled a lot. And so she had a tranexamic acid, she had a Bacra balloon inserted, she went to ICU, and she dropped her hemoglobin down to 46, and I came on the next day, and I was on call, and I was the lucky one having to be there when the Bacra balloon was going to be removed, so we had cell salvage and everything there. Anyway, it went well. However, it was interesting, the gynae registrar had just come out of the room, the patient was in tears, she was tachycardic, and the gynae registrar told her that she has to accept blood, otherwise she would die. I didn't think that that was particularly helpful, and so we didn't transfuse her, but what Georgina had done on the operating table, once the bleeding had stopped, she gave her on the table a gram of carboxymaltose. Now, she went to ICU, dropped her hemoglobin the next day, and this is sort of her course, her clinical course. She, carboxymaltose you can only give once a week, because it's set free from its carboxymaltose shell very slowly, but once a week you can give it, and the patient actually got carboxymaltose again before discharge. And also we encourage the obstetricians to test less, because also what's the point? You know you can't transfuse, and you draw blood, and we know, for example, our ICU patients lose roughly the equivalent of 1 unit of red cells in 3 days because of blood that's used for testing, but also for blood that's thrown out. And when I came in, I saw a very good system, which is now, I think, also in place in many ICUs here, which is a closed system, and you can aspirate and re-inject the blood that you don't use, so as you don't have to discard it. Now, the interesting bit about this story is, though, is that this patient came back to hospital 4 weeks later, and she had a mastitis. And the gynae registrar rings me really excited and said, "Oh, Bernd, do you remember that patient and the Jehovah's Witness? She's got a mastitis." And I said, "Please, I mean, of course, we shouldn't be testing when we don't have to." I said, "Just do a CBC." And so she did CBC because I wanted to see where she ended up. And I mean, in that short period of time, she completely normalized her hemoglobin. And yes, we did go a little bit overboard. We also did some iron studies. But this is really, really nice. This illustrates how powerful this intervention is if the patient needs it. This is another case that was published in the BJA, young trauma patient, 17-year-old guy who had a major trauma, again also Jehovah's Witness, bled down to 42 I think, and they were a little bit more conservative. Carboxymaltose had just come onto the market, and so the IV iron administration was a little bit conservative at the time. Now, very nice paper published from Calafala. How am I going for time? Okay. Sorry.
25 past 8.
Okay. So a very nice paper published by Calafala from Launceston. He's a hematologist who has a big interest in iron deficiency and anemia, and they randomized patients in the postoperative setting, and these were the majority of those patients were orthopedic patients. They were randomized to either IV iron or standard care, and all their outcome findings were a significant increase, 4 weeks post-op, iron stores better replaced, reduction of transfusion requirements. So post-operatively, you do have an opportunity to do something for your patient instead of transfusing. Also a very interesting study, and you will see that a lot of data is coming out of Australia. This is done by a group in Perth, also influenced by some people from the UK. Toby Richards is was in this group as well. He's a vascular surgeon from London, and they randomized ICU patients, IV iron versus placebo in the anemic patients. They didn't reach significance. They were probably a bit underpowered. There were 70 patients in each arm for the reduction in transfusion, but there is, as you can see, there is a trend. But what they did find at discharge was a significant increase in hemoglobin. And what is also interesting and very often discussed is the risk of iron administration and infection. They did not find any difference in infection. And Michael Auerbach, the physician from the States, in many of his papers also says there is actually no real data that shows that that is happening. So, and when we think about infection, the potential infectious risk by immunosuppressing the patient, I think you have to balance that out and have to make, obviously, that call what you want to do. So what's happening at the moment? The Australian government is quite active. Canberra instructed the Australian Commission of Safety and Quality to initiate a national patient blood management collaborative. We are lucky enough to be on that. That was tendered. I applied. We got funding for a 0.2 FTE for over 18 months. And there is 11 hospitals nationwide that participate and feed data into a central database, and at the time it was decided to look at patient groups that are at risk of iron deficiency, so gynecological surgery, orthopedic surgery and gastrointestinal surgery, so 3 patient groups, and we do this here in Adelaide in collaboration with the Women's and Children's and Modbury Hospital, and so really the collaborative wanted to look at these patient groups and wanted to look at potential improvement in patient blood management. Now, and this is data sort of over the time of the collaborative, and that was at the beginning. And all all the hospitals had obviously a project officer, which is in our case a transfusion nurse, so we did education in all those disciplines, education and pre-admission clinic, and you can see the increase over time of the preoperative assessment of iron deficiency. So it really skyrocketed, but you can also see it takes about a year for it to really bite and take off. And then where there is still a bit of room and improvement is when you actually diagnose this iron deficiency, how to manage it. So there's still a number of places that don't manage it well, but look at transfusion. This is data from 9,000 Australian patients in these 3 specialities, and the transfusion is dropping off by the day. And what we have done at the Lyell McEwin, we developed a couple of resources. So this is what we call the patient blood management care plan. So in pre-admission clinic, this is an official form. When you see your patient, you can circle who they belong to, you can tick, 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 and then you can follow up, you can write down what tests you've done, and on the back of this form is a little bit of a flow chart that shows you how to investigate iron deficiency and how to diagnose it. That's just a different form. The patient gets my iron plan, so they get information written if they get any treatment that they can take to their GP. And here's, for example, if you put this in and then we follow them up and we say, okay, they had a trial of oral iron, didn't respond, get IV. And so that everybody knows who looks at the notes what actually had happened. Now, this is work in progress, and unfortunately that collaborative finishes the middle of this year, and therefore the funding also. But I really hope that this is actually impressive enough for our administrators to say, well, we continue that funding. You don't need a big FTE for this, but you need a dedicated person who helps you with that. And then we developed also these templates for the GPs and also for the patients, so that everybody knows what's going on. And when we send it out to the GP, we also send a bit of an educational tool. This is from the National Patient Blood Management Guidelines. Again, a diagnostic flow chart, how to treat or how to identify and to treat iron deficiency. And these are sort of kind of little information brochures that the patient gets. Then we also put this up on the NAL and PPG, and there's some guidelines with lots and lots of resources that also the GPs can access on the South Australian website. Now, we know now there's a lot of evidence. What you need, or what we have as clinicians, we have the responsibility to look at that evidence and to treat patients appropriately. You do need a bit of passion for this, but you do need someone who takes that actually in their hand at your local hospital, or ideally a group of people. We have to do a lot of education, but it will pay off. And we also know, and I'm absolutely certain in the long term, that we will achieve really improved patient outcome. What's still a little bit controversial, but again, I believe that will also come out in the long term, that we should treat this a little bit more aggressively, is the non-anemic iron deficient patient. So yes, you can say, okay, my patient for my joint replacement who comes with a hemoglobin of 132, the male patient, but has a ferritin of 5, he can have a surgery. But we know also from cardiology data that ferritin of 5, so the iron deficiency alone actually has a big impact in terms of exercise tolerability or exercise tolerance and cardiac function. And there is a couple of very nice trials that show that iron replacement actually improves cardiac function before any changes to hemoglobin occurs. And this is also discussed in the obstetric space, and we're doing a large randomized controlled trial currently at the Lyell McEwin, looking at those patients. And so and then again, this is all fairly recent, so don't wait for the hemoglobin to drop. Patient blood management is not only a Lyell McEwin thing, it's not only an Australian thing. This is Germany, this is Italy. The European Union has put a lot of money aside for it, America, and then there's the Patient Blood Management Awareness Week in November, so I'll keep advertising. And you might recognize at least one of those people. This is also a safety issue. There is the Patient Safety Summit's been going on since 2013. This organization has a very ambitious goal, and they say 0 avoidable death by 2020. And Bill Clinton with his foundation puts a lot of money to this. Arya Shander, who is a good friend of mine now and who I visited initially to learn a bit about patient blood management, gave a very nice presentation at one of their meetings. And they always have for these summits the sort of actionable patient safety solutions. And one of the challenges that they listed for this year's summit was anemia and transfusion, a patient safety concern. And they really make the point that hospital leadership has to support a patient blood management program in the interest of the patient. Now, If you want to get started, this is a simplified approach, and it just tells you a couple of points that could be, should be done. This was just published a couple of weeks ago with a couple of international people, and I'm quite proud to be in this sort of group of people. But it's really a nice little paper that you can read between cases, and it might give you some ideas. So in summary, patient blood management, in my view, is the key. It has to be done with all other specialities that look after your patient. I think both iron deficiency anemia and iron deficiency need to be treated. IV iron certainly has a role in the postoperative setting and possibly in trauma. There is no one-size-fits-all approach. You have to look at your patient. Every individual patient needs to be treated. Now, I would love to show you one case, and I think we have time for that, and then have 10 minutes for discussion. This is the almost perfect case. This is, I think, one of the group of patients that we forget quite often is the obstetric patient. About 40% of those patients we actually will deal with. 30% of women have cesarean sections, and so we know that patient blood management, pillar 1, optimizing iron and optimizing hemoglobin, is important prior to surgery, where there is a potential for blood loss. And we all know women bleed. They sometimes bleed big time, and they bleed very unpredictably, and they bleed sometimes very fast. So we at the Lyell McEwin have a 24/7 cell salvage provision. There is obviously other elements to patient blood management than just treating with iron. So there is a concept of intraoperative, postoperative, preoperative. And intraoperative, there's cell salvage, there's proper hemostasis by the surgeon, there's tranexamic acid, there is keeping the patient warm, positioning, all the things we know from the past, but they were incorporated into patient blood management. The reason why I call this the almost perfect case is because we have criteria where we set up cell salvage for cesarean sections routinely, and that patient actually fitted those criteria. She had previous children, she'd been in labour for a long time, and we adopted these criteria from a hospital in the UK, Liverpool Hospital, where they did a lot of cell salvage in patients. Anyway, this lady, even though she had a vaginal or multiple only vaginal deliveries in the past, there was fetal distress, and so she was booked for an emergency section. And then one of my colleagues rings me and says, "Oh, can you come quickly into theatre 2?" So she bled, but they didn't have cell salvage set up, but we have a cell saver sitting in theatre ready to go. And we only have to connect really the suction and the heparin, and spike the heparin. So we have one in the obstetric theatre, and that is run 24/7. All our anaesthetic nurses are capable of doing this, and most anaesthetists now know what to do and not to do. So this is just the intraoperative. So they actually had to convert from a regional to a GA. The lady bled close to 3 litres. Now, but when you look at this is now patient blood management in action. This lady was anemic. And not only was she anemic, but she was identified as being iron deficient because our obstetricians now screen quite routinely for ferritin levels at 28 weeks. So she had an iron infusion. So she came up with a hemoglobin over a very short period of time to a normal hemoglobin, 126, and then she bled. Now, she bled to 68. If she would have bled from 99, she would have been in dire straits, and she would have been transfused, guaranteed. What we did is we salvaged. We didn't unfortunately salvage everything, so about 1 litre and a bit went into the bucket, and the rest then into the cell saver. We processed this blood, and we gave her back close to 1.5 units of red cells. And so after that reinfusion, she had a hemoglobin of 90, and she dropped down with her hemoglobin on the postoperative day. She had another CBC, so she dropped down a little bit to 77. But she was hemodynamically stable. Intraoperatively, we also read a ROTAM because she had a massive hemorrhage, so we wanted to find out whether she had a coagulopathy. And so we routinely, if we run a ROTEM, we do an XTEM and a FIBTEM. And obviously, as we all know, fibrinogen is very important. Her fibrinogen levels were absolutely fine. Her FIBTEM A5 is 13 mils, which is sufficient in obstetrics. So this lady did not get any product. She got her own red cells back, and then, this is the third pillar, the obstetricians who are really on board with this, they tolerated that patient's anemia. This is the discharge summary, post-op hemoglobin, her own blood, it was slightly different on the record, patient hemodynamically stable, not symptomatic of anemia, and she had another iron infusion before discharge. And I think this is really well done. And with this, I finish, and if you have any questions, please feel free. Thank you. Convinced?
Any questions, anyone?
Is there any level of hemoglobin where you can sort of assume that the ferritin levels are normal?
No. I mean, you can have iron obviously circulating in your red cells, but you can have completely empty iron stores. So we see this quite often, that you have high hemoglobin levels and you still have completely depleted iron stores.
So can you talk a little bit more about the potential infection risks associated with IV iron? I mean, you put up a study there that had relatively small numbers of patients.
Yes.
So the question is, was it actually adequately powered to detect a change in infection rate?
No, they weren't. They weren't.
For the, from the international community.
Yeah. No, you're right, Simon. And the thing is that they were not powered to detect infection, and this is also. In many other studies, these studies were underpowered to detect infection. However, in big observational studies, we also find that there is no increase in infection in patients treated with IV iron. I think what the approach that a lot of people would possibly take is, at this stage, if your patient is, let's say, moderately anemic and you think they're iron deficient, or you have actually diagnosed they're iron deficient, but let's say they're septic, you could also argue, why not wait? Because if they're treated for their sepsis, and you can wait a couple of days and then treat them appropriately with iron if you want to do that. So I think in sort of real sepsis, I think there's probably other things that you might be concerned about than treating that iron deficiency aggressively. So, but the consensus still is at the moment, and again, I can only really recall this from the literature, is that there is no increased risk. But I also am aware that this is an area where people are still quite cautious.
When I anaesthetise joint arthroplasties, I know they're going to lose 500 to 1,000 mils, probably each one of those patients, so they're going to be losing iron. Is there an argument for giving some intravenous carboxymaltose along with the tranexamic acid in every case?
I wouldn't necessarily give it along with the tranexamic acid, unless you're talking about the dose that's given postoperatively. I mean, I don't know I don't think there is a statewide protocol, but some units give it before incision and then again after surgery over a certain number of hours. But there are some studies, and again, this is this study, for example, from Kalafala, where 82% of those patients were orthopedic patients. They got their iron post-op, and only post-op. This was only iron replacement post-op. And again, you lose, they're losing, if you lose 1,000 mils of blood, you lose 500 milligrams of iron. And if you're already low, you have nothing to draw on. And
why not just cut to the chase and give them some intravenous?
Well, a lot of people would completely agree with you that this is the way to go. Go.
You ceased your trial after 32 patients, which is a small number of patients, and I guess the end...
No, after 72 patients.
Yeah, 72. It's a small number.
Yes.
And your endpoint was hemoglobin. I guess my question would be, would you be prepared to repeat your trial, and instead of randomising to usual care, would you be prepared to randomise IV iron against placebo?
RB iron versus?
Placebo.
Personally, I wouldn't. I mean, that's my personal opinion. Also, I know that I don't have to because this trial is undergoing. And this is currently undergoing in the UK. It's called Prevent. And it's a multi-centre trial with 250 patients in each arm. They've got a long way to go, but this is currently happening. I argued very, very hard in our manuscript that we cannot withhold a treatment for patients with a treatable condition. And what I believe is if you have a condition that, we wouldn't withhold an ACE inhibitor for a patient that has hypertension. Well, some people do, and we have a reason for that sometimes in the perioperative setting because of the duration of action, whatever. But what I'm trying to say is we wouldn't withhold insulin all of a sudden and not treat the diabetes. And so if you have a condition, you should treat it. And therefore this debate is really difficult. And of course, I, for example, at the beginning when we tried to find collaborators in South Australia for our trial, and we were powered to 125 in each arm, surgeons didn't want to come on board because we didn't randomise versus oral iron. So in a way, they already sort of kind of had that debate, how can you do that? You can't diagnose. I guess the interesting bit is, and that we had this discussion last week, there's also a cardiothoracic trial currently underway out of Melbourne. Paul Miles runs this study. It's an international study where they got around this by including patients who are anemic. And we had our inclusion criteria was iron deficiency anemia. So we diagnosed iron deficiency. Again, it was a very generous inclusion of the definition of iron deficiency. But when you look, for example, at the renal guidelines and the renal impairment or the CKD guidelines now for treating iron deficiency, they push their ferritins up to 500 or more. And so I guess in combination with inflammation, it is probably advisable when you monitor your transferrin saturation to provide those patients with the substrate. So no, I wouldn't repeat this. And I think what would be interesting is if you repeat this and you randomize the versus oral iron, but we also kind of would have to change the enrollment window because we know 4 days prior to surgery your oral iron won't provide much. Yeah.
But I really enjoyed that. In your last case, the obstetric case, what would be your transfusion trigger here?
So asking transfusion trigger, again in the obstetric population we usually try and avoid transfusion with hemoglobins above 60. I know when we started this there was a lot of nervousness around this, and I remember we had a patient who bled down to 54, but she was completely stable, she was breastfeeding, she was mobilizing. And the gynae registrar rang me probably 5 times a day and kind of reported the hemoglobin values. And I said, well, how's your patient? Oh, she's fine. Well, then not transfused. I mean, that is maybe pushing the envelope a little bit, but we know from, obviously, again, the Jehovah's Witness population that you can, I think your critical hemoglobin in the sort of healthy patient is probably somewhere around 40, 45. And the lowest I personally have seen was 1.9, and the lady survived this. But again, that was a Jehovah's Witness patient. But I think the importance when you do go that far is that you have to make sure that there's no ongoing blood loss and also that you can monitor your patient appropriately. But in the young adult, you can, I think, reasonably safely do that.
And sorry, if someone had a history of stroke or stable ischemic heart disease, I don't think like the word trigger or transfusion trigger for that person.
Sorry, say that again.
So if someone with a history of ischemic heart disease or a history of stroke, what do you number as?
Well, this is obviously also the big debate. And there's a couple of studies that compare restrictive versus liberal. There's a couple of meta-analyses, and I think the consensus for a long time was the 7. However, in patients with coronary artery disease, I think that the international community kind of accepts now that 90 is the goal that you should try and achieve. But certainly not the 100 that we used to always have in our head for most patients. So with patients with coronary artery disease or cerebrovascular disease, I think when you read the literature that clinicians would usually transfuse to between 80 and 90.
Just a practical question. When I'm at, if you identify someone with preoperative needs IVI, who takes responsibility for it?
That's a good question. I mean, at the moment, we spread this out reasonably well. So particularly our colo-rectal colleagues, they quite often take that in their own hands. But most of the time, we see them in pre-admission clinic and then we organise it. So the anaesthetists organise it. Our surgical admission unit does the infusions for us. And quite often, if we have a system in place now where we like let's say I do clinic on a Monday and the next person on the Tuesday has to review the results from Monday. So we try in a very short period of time to identify patients with a problem and then act on that. If you already, and what our colorectal colleagues quite often do is when they, let's say they have a colorectal cancer and they see the patient the week before, they already do the appropriate tests. So quite often I'm the first to review those tests in my clinic, and sometimes we manage to get these patients in for an iron infusion on that day. So we just ring them, and carboxymaltose is very easy because it takes only 15 minutes. There's a study in Melbourne where they do it in a 10-second push. So it's undiluted, 10 seconds, boom, 1 gram, and apparently from what I've heard is that patients tolerate it quite well. This is a bit tricky. I mean, obviously, as we all know, iron polymaltose, and we as per South Australian therapeutic regulations, we have, for inpatients, have to give iron polymaltose because it's the 10th of the price, even though it takes 4 to 6 hours if you give a full dose. And this is quite labour intensive for nursing staff on the ward. In the non-pregnant patient population, we do the 15-minute infusion and we keep them for another 15 minutes. So the patient is actually there for half an hour. And what we normally do is the day before, if we book the patient in, I write the chart. It's on PBS, so you have to write a drug chart, you have to write a PBS script, you have to notify the patient of a co-payment. You know, if you're a concession card holder, it's $6.90. If you're not a concession card holder, it costs you $36. Pharmacy invoices the patient, so you've got nothing to do with the payment. But the drug is already dispensed the day before. So 2F, our admission unit, they have the drug there. The nurses ring one of us, and all the registrars been there. You put a Gelco in, the patient gets the iron, they get monitored for 15 minutes, and they go home. And so that's fairly straightforward. I wish I would have a dedicated iron infusion clinic. It's a nice business model. I think we have to wrap up. Well, thank you very much for coming out tonight, and very much appreciated. Thank you.